About 2% of the population, the world population is affected in United States, the population of US, and high rates of psoriasis have been found in Faroe Island. The prevalence of psoriasis is low in Japan and may be absent in Australians, Indians. Psoriasis can be present at any age, but there is a bimodal age of onset has been recognized, and the mean age of onset for first presentation of psoriasis can range from 15 to 20 years of age, and second peak occurs at the 55 to 60 years. So it has got a bimodal peak. Here you can see the distribution, the prevalence of psoriasis worldwide. There is the color code. In India, it's 0.5 to 1. As I told you, it's below 1. And in a part of US, it's high. It's more than 2.5. So what is the pathogenesis? This pathogenesis of the skin by activated T cells which stimulate proliferation of keratinocytes is involved in pathogenesis. Now, T cells which play a key role with epidermal T cells be CD8 positive, CD8 plus, and the dermal cells that being mixture of CD4 and CD8 cells. Majority of these cells are memory T cells expressing CLA, that's, and the skin homing receptors, and chemokine receptors, CCR4, but natural killer cells, T cell may be important. So all these kinds of T cells, they play a role in the pathogenesis. Now keratinocytes, they express the transcription factor ST83, which may be pathogenic. Langerhans cells, they secrete cytokines, which are mitogenic and chemotactic. And there are some signaling molecules. Those are the cytokines, chemokines, and growth factors and their receptors. Okay. The infiltration of skin by activated T cells that stimulate the proliferation of keratinocytes. So there are hyperproliferation of keratinocytes. As I told you, cell turnover time is low. And this dysregulation in keratinocytes turnover results in formation of thick plaques. Other associated features include epidermal hyperplasia and parakeratosis. In addition, the epidermal cells fail to secrete lipids, which result in flecky and scaly skin, which is typical of psoriasis. This flecky and scaly skin. So there are many other lesions like seborrheic dermatitis and all. So scales are produced in those lesions also. So there is a difference between the scales of the psoriasis and the Now, what are the clinical features? Mainly the diagnosis is done by clinical features. Histopathology is rarely necessary. So the presenting features are well-defined erythematous plaques covered with silvery scales, commonly over the scalp. Extensors of the extremity, particularly over knees and elbows and lumbosacral region. There are two types. Type 1 is the type 1 which has a positive family history. Usually, it's not always, but it's usually there's a positive family history and it starts before the age of 40 and it is associated with the HLA-CW6 antigen. Type 2 that does not show a family history and it presents after the age 40 and it is not associated with HLA. Now there are morphological variants. The plaque psoriasis, which we call the chronic plaque psoriasis or the CPP, guttate psoriasis, rupioid psoriasis, erythrodermic. Sometimes the erythrodermic psoriasis can occur as a complication to the plaque psoriasis. Pustular psoriasis, inverse, that is flexural, that means the psoriasis usually involves the extensor surface. When it involves a flexure surface, then it is called the inverse psoriasis. Elephantine, that psoriasis, psoriatic arthritis. The variation in site is seen with involvement of scalp, palmoplantar region, genitals, and nails. Any injury to skin in patients with psoriasis in the form of either mechanical, as I told you, mechanical, chemical, or radiational trauma induces lesions of psoriasis at a site which is called Koebner phenomenon. And if the Koebner phenomena occurs, then it indicates the activeness of the disease. Now the plaque psoriasis or the chronic plaque psoriasis, you can see in the diagram, in the picture, the erythematous plaques with silvery scales, most commonly over the extensors of extremities, on the elbows, knees, scalp, back. It is the most common type of psoriasis which affects 85% to 90% patients. On successive removal of psoriatic scales, there is pinpoint bleeding points, and this is known as OCULAR sign. In the next slide, I will show you how it is performed, the test to see the OCULAR sign. And the feature is that it presents as this plaque and the silvery, the papulosquamous lesions and with silvery scales, and mostly they are bilateral. So if someone presents with at a single side unilateral, then it is very common that within few days or few weeks or a few months, the person will invariably develop the lesion on the other side. Now this is the bedside test. The GUTTATE test scales in psoriatic plaque can be accentuated by gratting with a glass slide. You will take a glass slide, and this is done in OPD, and this can be accentuated. The plaque can be accentuated. Step A, gently scrape the lesion with glass slide, and this accentuates the silvery scales. The GUTTATE test positive. Scrape off all the scales. When you scrape the lesion, in the step B, when you scrape the lesion, like if you are, this is the glass slide. Okay, and it accentuates the silvery scales. As you continue the scrape, and glistening white adherent membrane appears. This is known as Barclay's membrane. Okay. When you remove the scales, and on removing the membrane, puncted bleeding points. There will be the puncted bleeding points become visible, and this is positive auspicious sign. This is positive auspicious sign. Okay, so there are 3 steps for scraping. Then after scraping, the membrane appears, and then the positive auspicious sign. Rupert psoriasis, there is hipped up scales so that the lesions appear conical. These lesions are conical. Scales are firmly adherent to the underlying skin. Such lesions are classically present in Rita's syndrome, which is characteristically associated with HLA-B27. Preceding infection will be there. Preceding infection, inflammatory arthritis, keratoderma blenoragicum, sarcinate baranitis, iridocyclitis. These are the associated features with rupioid psoriasis, because these are the features of the Rita's syndrome also. When you find the patient is HLA-B27 positive. Next is gutted psoriasis. Now, in gutted psoriasis is commonly seen in children after upper respiratory tract infection with the streptococcal organism. Now, it presents as the erythematous and scaly raindrop-shaped lesions, mainly over trunk and back, and it has got best prognosis. Next is the pustular psoriasis. As the name implies, there will be collection of pus, and there will be small non-infectious pus-filled lesions with erythema surrounding it. There are 2 types. One is the generalized and localized. Generalized means extensive lesions, and it is associated with hypocalcemia, and it presents with sterile pustules. So if you take the pus and do a culture, it will not reveal any infective agents. On an erythematous plaque and involving the whole body, the sterile pustules. Psoriasis of palm and sole, the palmoplantar psoriasis. It has got the bilateral involvement. Tinea amanum at pedis is unilateral. It's the differentiating feature. Symmetrical, well-defined, erythematous, thickened plaques. Silvery scales may be profuse or minimal. And scales may be adherent on the palms and soles, unlike loose scales on other parts. Erythema less obvious because of the thickness of the stratum corneum. As the stratum corneum is thick here, so erythema is not that much prominent. The erythrodermic psoriasis. This is widespread inflammation in the form of erythema and exfoliation of the skin. It covers more than 90% of the body area, and it is associated with severe itching, swelling, and pain. And if there is a stable plaque psoriasis and the lesions exacerbate, that can take a form of this erythrodermic psoriasis. So complications of erythroderma include impairment in the barrier function of the skin, disturbance in basal metabolic rate, increased cutaneous circulation, in turn affecting the heart with cardiac failure. So there are many evidences that psoriasis is associated with cardiac events and cardiovascular disease. The nail changes. The nail changes in psoriasis, they are the pitting. There will be pitting in the nails. There will be oil spots. You can see these are the spots. subungual hyperkeratosis, it's in the nail bed, nail dystrophy, and onycholysis, ankylosis. Okay. These are the changes that occur in nails. Now, it can also involve the oral cavity. If it involves the oral cavity, there will be fissure in the tongue, and it's the most common finding of oral psoriasis and has been reported it to occur in 6.5 to 20% of people with psoriasis affecting the skin. This is inverse psoriasis. Smooth, erythematous, sharply demarcated patches affecting intertriginous areas like groins, armpits. Here you can see the psoriasis involves the armpits. Inframammary region, moist, macerated, may contain fissures which may be malodorous, pruritic, or both. Differentiating features is dermatophyte infection that also affects these sites, but that presents with central clearing. Now, sebopsoriasis is a form of psoriasis which typically manifests as red plaques with greasy scale. Usually, in typical psoriasis lesion, the scales are silvery scale, not greasy scale. But when it occurs in the greasy scale, it commonly affects the areas with increased sebum production, such as the scalp, forehead, nasolabial fold, sternum, retroauricular fold. Actually, where the seborrheic dermatitis occurs. So this is to be differentiated with the seborrheic dermatitis. Now, psoriatic arthritis, chronic inflammatory arthritis, which affects 30% patients with psoriasis. It commonly occurs in association with skin and nail psoriasis. There is painful inflammation of the joints and connective tissue, commonly affecting the joints of the fingers and toes. You can see in the picture, there is involvement of the digits and involvement of the middle and the distal interphalangeal joints in the middle finger. Then not the middle, it's the distal phalangeal, proximal and the distal interphalangeal joints. So, sausage-shaped swelling of the fingers and toes known as dactylitis. And psoriatic arthritis can also affect the hips, knees, spine, presenting as spondylitis and sacroiliac joints with sacroiliitis. So it can involve different joints. There is ocular involvement. Psoriasis also affects the eyelids, conjunctiva, cornea, giving rise to trichiasis, ectropion, conjunctivitis, and corneal dryness. The most common eye feature is blepharitis, which can lead to cicatricial ectropion, madarosis, trichiasis. So these are the presenting features of ocular psoriasis. In some cases,
excuse me, ma'am.
Okay. Am I audible now?
Yes, ma'am.
Okay, thank you. So psoriasis also affects the eyelids. As I told you, the features of the ocular psoriasis, the ocular involvement that present with these conditions. And as I told you, the psoriasis can occur in the genitals also. Those are the penile psoriasis. And in penile psoriasis, if there is circumcision, then no scaling is there. The scaling will not be there. And if there is uncircumcised patients, then they can present with scaling and the usual features. Now, diagnosis is mainly by the clinical morphology. Histopathology is not usually necessary, but may help to differentiate psoriasis from other dermatosis, and if the diagnosis is not easy. So what are the other investigation? That biopsy that shows changes like parakeratosis, the microabscess, the absence of granular lesions, regular elongation of ridges in the form of camel foot appearance, spongiform pustules. These are the pathological features. Spongiform pustules of the cogos with dilated and tortuous capillaries. These are the actually what I told you, the pathological changes or the histogenesis of the epidermis and the dermis. Those can be seen if biopsy is done. Now, what are the investigations? These investigations should be done for differentiating with the other disease and as well as to choose the treatment option. One should order for complete blood count, renal liver function test, rheumatoid factor if there is joint involvement. ESR may be elevated in erythrodermic and pustular psoriasis as there is inflammation. Inflammation is high. Uric acid levels are high in psoriasis. If only hand and feet are involved, obtain scrapings for fungal studies so that it can be differentiated from dermatophytes. Pregnancy test. Pregnancy test is done to choose the therapy. Hepatitis serology and purified derivatives, PPD, is tested. Now, reassurance and the emotional support are invaluable. When once the psoriasis is diagnosed, then you have to counsel the patient first. That you have to inform the person that it is not curable, but it can be, it has the remissions and relapses, and it is not contagious, it is benign. The treatment available are suppressive, not curative. Several treatment options are available. Physical activity and mental rest may enhance the effect of specific therapy. Now, treatment. While choosing the treatment, psoriasis area severity index, it is most widely used measurement tool, which assesses the severity of the condition and allows to evaluate the treatment efficiency. So the area severity is the body surface area. That index is required. So topical therapy is used in mild to moderate psoriasis. Emollients and moisturizers may help in improving the barrier function and retain the hydration of stratum corneum. So along with the topical agents, usually the emollients are also prescribed, or we ask the persons to use the emollients along with the topical agents. Topical agents used are coulter, diethranol, corticosteroids, vitamin D analog, and retinoids. Now, coulter is used in 3 to 6% preparation and is formulated in petrolatum, often with salicylic acid, in chronic plaque psoriasis with the BSA index less than 10%. Diethranol 0.05 or 0.25 to 2% formulated with salicylic acid. When there is few large plaques, when the plaques are large, we can use diethranol. Calcipotriol is a very good agent and it can be combined with topical steroids in patients who finds the above the above two agents unacceptable. And this calcipotriol, as it is expensive, so we can give it to the affluent patients. Tazarotene 0.05 to 0.1% and they can be combined with coal tar or topical steroids. Now, what about the topical steroids? Topical steroids can be given to psoriasis, but the use should be judicious, as we cannot give it for long term and withdraw suddenly. There will be exacerbation. So it has to be tapered. And these corticosteroids are only used topically. In psoriasis, corticosteroids are never used in systematic form. Now the drug of choice, systemic drugs are, the methotrexate is the drug of choice and it should be used as long as it remains effective. When it is not effective, then we can go to another drug. The cyclosporine can be used to induce a clinical response, but its use should be intermittent, not long term. When the patient fails to respond to methotrexate, switch to biological agents. Those are known as the biological response modifiers. In some cases, combined with methotrexate. Methotrexate, then the test dose, often it can be skipped, 2.5 to 5 milligram with a test hemogram and LFT is mandatory. And regular dose is 7.5 to 25 milligram weekly for an adult orally. Always add folic acid 5 milligram weekly to reduce the side effects. Generalized pustular psoriasis or the erythrodermic psoriasis, chronic plaque psoriasis which are unresponsive to conventional therapy, palmoplantar psoriasis. In palmoplantar psoriasis, we can give methotrexate in small dose. So these are the indications where we use methotrexate. Acitretin 25 to 50 milligram daily, preferably after meals in pustular psoriasis and psoriatic erythroderma. Cyclosporine again used in pustular psoriasis and psoriasis erythroderma. The daily dose will be 3 to 5 milligram per kg and then it is to be tapered off. And we cannot use cyclosporine for a long term. Therapy should be intermittent. Next is the phototherapy. The phototherapy includes PUVA and therapy which combines psoralen with exposure to ultraviolet light, UVA, as well as UVB is obsolete. Now UVA therapy is done, as well as the narrowband UVB light with a range of 311 nanometer to 313 nanometer is equally effective without the side effects of psoralen. Psoralen has got side effects like gastrointestinal upset, cataract formation, carcinogenic effect, and it can be given to children, pregnant women and lactating females, and even elderly. And gutted psoriasis has known to respond best to phototherapy, and it is safe in children. Now, photochemotherapy, the drug used is 8-methoxypsoralen, 0.6 to 0.8 milligram per kg, less frequently trimethyl-psoriasis. The dose is 1.5 milligram per kg and it's taken after breakfast on alternate days, an application of petrolatum, and it is followed by exposure to UVA after 1 hour, 1 to 2 hours. It is indicated in extensive chronic plaque psoriasis. Those are resistant to topical treatment. Psoriatic erythroderma. Now there are 3 variations of PUVA therapy. PUVA solar energy, the PUVA sol, that is the solar energy as the source of UVA. Topical PUVA, the PUVA sol, UV exposure, half an hour after application of topical psoralen. Bath PUVA, that's soaking in bath water containing trimethyl-psoralen and immediately exposing to UVA. What we use in the solar energy, that we ask the patient to take the sun bath. Okay. After applying the agent, applying the topical agent. Now treatment, the systemic drugs. Already I told you the methotrexate, retinoid, cyclosporine, fumarics are possible options. Routine blood liver functions are mandatory and renal function that should be monitored during this therapy. Now biologicals, the biological response modifiers, those are introduced when the other treatment fails. Those are infliximab, adalimumab, etanercept, interleukin antagonist. Before starting any biological agent, the patient should be walked up for tuberculosis and hepatitis because there can be flare of these infections. There are high chances of infections. As these are immunomodulators. So what are the precautions? Prolonged use of steroids and other immunosuppressive may delay the wound healing. Ocular psoriasis needs aggressive treatment with topical corticosteroids. All skin trauma should be avoided for fear of inducing Cobnus reaction. And use of beta blockers, chloroquine, other NSAIDs, the drugs, those are the triggering factors, psoriasis, should be avoided. And they should not consume alcohol because of the risk of developing fatty liver. Differential diagnosis is eczema and seborrheic dermatitis. Seborrheic dermatitis, there is the skin, it will be itchy, will be more itchy than the psoriasis. The itching is less in psoriasis and the lesions will be more indurated in psoriasis. Pityriasis rosea, and pityriasis rosea is self-limiting disease. And there are many the lesions, the signature lesion is the hairal patch will be there for pityriasis rosea. Mycosis fungoides, it's a form of T-cell lymphoma. We can differentiate it by biopsy. Secondary syphilis, this is very rare nowadays. Now, quality of life. Psoriasis is a chronic condition which is having negative impact on the quality of life of the patient and as well as the family members. It's a lifelong illness and it is marked by relapses and remissions, and those are also very unpredictable. Now, about 10% of the patients develop severe deforming arthritis. Remissions are experienced in 10 to 60% of patients. Over the course of the disease, psoriasis has been associated with depression, suicide, alcoholism, smoking, substance abuse, metabolic syndrome, and a variety of skin cancers. Major medical comorbidities are associated with kidney disease, heart disease, joint problems. Several studies have noted a link between psoriasis and adverse cardiac events. There are more and more evidences are coming up that link the cardiac diseases with psoriasis. Now, pustular psoriasis and erythrodermic psoriasis may be life-threatening, while psoriatic arthritis affects the functional prognosis negatively. Now, the complications are secondary infections, poor cosmesis, psoriatic arthritis, risk of lymphoma, increased risk of adverse cardiac events. Patient education. It is needed to be told that there is no specific diet for psoriasis. Patient should eat a healthy diet. Patient should be educated on reducing the risk factor for heart disease. Exposure to sunlight is beneficial, and patient should be encouraged to spend time outdoors. In addition, patient should maintain healthy body weight. In the clinic, they should be screened for type 2 diabetes, hypertension, dyslipidemia, and finally, consultation with a psychiatrist is beneficial. Now, there are some guidelines, the treatment guidelines. Psoriasis is considered extensive when more than 10% BSA is involved. When the condition occurs on face, nails, scalp, genitals, plexus, soles, it is also considered severe, as these areas are hard to treat and they are associated with poor cosmesis. Biological therapy should be considered early if methotrexate is not well tolerated. Now, assess response to treatment by noting a reduction in baseline disease severity and improvement in the physical, social, and psychological function. We can assess the treatment, how they are responding to treatment. Ustekinumab, it's the first line biological. These are the biological agents. It's the biological agent of choice, and secukinumab is another alternative. Adalimumab is the first line biological agent of choice in patients with arthropathy who has got a joint involvement. Infliximab is reserved for the patients with severe disease when the other biological agents are not working. Women with childbearing age who started on biological agents should start effective contraception, because these are not indicated in pregnant women. Live vaccines are to be avoided on people taking biological agents. All vaccinations must be complete before starting the biological agents. Patients with demyelinating disorders should not be treated with TNF antagonist, and patients with heart failure should not be treated with TNF antagonist. Now, psoriasis is not only a disease of the skin, it also involves the other departments. So it can be managed when the other departments also they play a role, like the nephrologist, plastic surgeon, pharmacist, rheumatologist, ophthalmologist, and they all should manage these patients. So the key goal is to improve the quality of life by educating the patient about avoiding the triggers. The pharmacist should educate the patient on the use of moisturizers, managing the dry skin, and compliance with the medications. The nurse should educate how to take the emollients, when to when to be exposed to sun, how much time should be spent. So they should monitor the patient for self-harm and refer the patient to the mental health counselor. Finally, the patient should be told to eat healthily, exercise regularly, and maintain a healthy weight. All patients with psoriasis need lifelong follow-up because relapses are common and unpredictable, as I told you. An interprofessional team approach to management will yield improved outcomes. Now, what are the comorbidities? Though it is a benign skin disorder, but there are some associated comorbidities. The cardiac events, cardiovascular disease, and the psoriasis is associated with alcoholism, smoking, depression, risk of lymphoma, the complications, and hypertension, renal disease. And psoriasis involving the palms and soles, they tend to have much poorer quality of life because there are poor cosmesis and than those who have psoriasis on the other parts. Psoriasis has been known to be associated with various psychiatric comorbidities like depression, anxiety, adjustment disorder, persistent stress, impaired sexual and marital life. Now, in our institution, one study has been conducted that 149 consecutive patients were studied in a study by Venugopal and others in COMGNMH, and the result revealed that a majority of the subjects, almost 98%, they had mild degree of anxiety symptoms. The majority of the subjects that had minimal depression, whereas near about 2/5 of the subject had mild to severe depression. So these are the findings of the study we conducted. Thank you. And it's the last line that I think it's time to love the skin, worry. It's to improve the quality of life. That is more important in psoriasis. Thank you, everyone.
Thank you so much, ma'am. This was Dr. Moumita Chatterjee, Faculty, College of Medicine and JNM Hospital, Kalyani, West Bengal, India. Thank you so much, ma'am, for being here and devoting your time. We would be seeing her again as the judge for the poster presentation competition on 29th of August. Now over to Urvi Jain, who would be briefing you with the final proceedings of the meeting.
Do you have any questions or any queries about psoriasis? Then you can ask me.
Yes, ma'am. Somebody has asked a question in the chat.
Okay.
Astithu Mittal asks, how should one differentiate between seborrheic dermatitis and psoriasis?
Okay. Now as the site of involvement, if in the seborrheic dermatitis and psoriasis, if it is same like the sebopsoriasis, how will be differentiated? First of all, psoriasis usually presents on the both side, bilateral, and the scales of the psoriasis are silvery scale, whereas in seborrheic dermatitis it will be greasy scale. There will be increased production of the sebum, and we can take the scrapings to find the dermatophyte with the KOH preparation. So these are the differentiating features, and the irritation, the itching will be more severe in seborrheic dermatitis, whereas the induration will be more in psoriasis. Any other question?
Yes, ma'am. There's another question. What is herald patch for P. rosea?
Yes, that's the herald patch. Is that when the Psoriasis rosea, it presents with a single patch. Mostly they are presented at the back, and from that the other patches appears, and those grow like a tree. If the first patch that appears, that is known as the herald patch.
Thank you so much, ma'am. Any other doubts? You can ask ma'am right now. Yeah. Does psoriasis itself, Mibadki, can you complete your question? I'm not sure what you're trying to ask. Or you can unmute yourself and ask. Does psoriasis?
Moumita Chatterjee, આપણે જો સુકા રીતે તો ભાઈ આપણે કપડા પહેરીને મામંત જાય પછી હા મામંત જાય હા
Ma'am, the question is, does psoriasis affect pregnancy?
No, that not the psoriasis doesn't affect pregnancy, but the treatments, sometimes the systemic treatments, the oral agents, some oral agents can affect the pregnancy. So for pregnancy, what we choose first, that as the first the topical agents, if it doesn't work, we will go for the phototherapy, the photochemotherapy that is safe in pregnancy. We will not definitely choose the methotrexate. We will not go for the biological agents. So oral therapy, we can give the phototherapy, photochemotherapy.
And there's another question.
Yes.
How are scales absent in penile psoriasis with circumcision, and why are they present without circumcision?
Yes, it's because of the skin that that is present in the uncircumscribed persons. So it can present the scale. If it is not there, the induration will be there, but the scales will not be there.
Ma'am, another question. So quickly asks, can people taking medications for psoriasis get the COVID vaccine?
Yes, we can get the COVID vaccine. As I told you that psoriasis patients, those who are having the those who are on the biological agents, they should avoid the live vaccines only. Okay, and even the COVID vaccines, these are not the live vaccines what we get here. So they can take the COVID vaccines. There is no contraindication.
Ma'am, another question is palmoplantar psoriasis a comorbidity or a separate type of psoriasis?
It's not a separate type of, actually the palmoplantar psoriasis is that form the psoriasis that involves this part. And what happens, the usual features are there. The scales will be adhered to the skin because there is thick skin. Okay, and there is poor cosmesis. That's it. It's not about the separate type or separate entity.
But ma'am, it can be called a presentation of psoriasis, right? A different for the palmoplantar psoriasis.
Yes, it's a presentation of psoriasis.
There's another question. Can we differentiate spondylitis associated with psoriasis from ankylosing spondylitis from clinical picture investigations?
Yes, we can. It will be evident on the investigation. If there is ankylosing spondylitis, then we can see the imaging, the blood investigations, and in psoriasis we can have different things. We will have the psoriatic features on the skin too. Okay, so there will be involvement of the psoriasis. There will be the involvement in the epidermal cells, the dermal cells, as I told you. So, and there will be involvement of the joints. And this involvement of the joints in the ankylosing spondylitis, those will be the typical ankylosing spondylitis. This will not be present in the psoriatic arthropathy. It will be of different types.
Another question is how psoriasis affects cardiac health.
Yes, how psoriasis affects the cardiac health. Psoriasis, there is no causal relation between the psoriasis and the cardiac events, but there is a temporal association. And as it has got a T cell immune process, an autoimmune process, so it can involve the heart. It can involve the heart, it can involve the kidney too. So the pathogenesis is not clearly known, but it will be like the other autoimmune disease, with the T cell mediated autoimmune disease.
Any other question? If you guys have any questions later, you can send it to me or Ravi. We will forward your queries to ma'am. Thank you so much, ma'am, for your time and explaining the disease and everything related to it to us so well.
It's very nice to be with you. Thank you.
Thank you so much, ma'am. We are looking forward to meet you again on 29th when we have our finalists presenting the posters.
Okay.
So thank you so much to my co-organizer Avi for managing everything so well. Thank you so much for the audience. All of you were very patient and an amazing audience. So as we all know that August 2021 is being celebrated as the Psoriasis Awareness Month. And as ma'am very well explained it to us, how psoriasis is not just a skin disease. It can have a lot of systemic complications along with severe mental health repercussions. So let's do our bit as medical students to spread more awareness, to reduce the stigma associated with the disease, and to help the patients have a better quality of life. And for being able to spread the correct information, all of us need to be correctly taught about the disease, which ma'am did very well. So thank you so much, ma'am. And as the ending note, I would like to say, as Lumina said, it is a long road to wisdom, but a very short one to being ignored. So let's do our bit. Let's take another step forward to fight this disease and spread the awareness to as many people who are affected by it, people who are not affected by it, people who are medicos and especially non-medicos. Let's take a step forward and spread the awareness about the disease. Thank you so much for being here, everyone. We'll be sharing a bingo sheet with you on the WhatsApp group. All of you can check what you have learned during the event. All you have to do is cut off the myths and share that on your Instagram and WhatsApp stories. Thank you so much for being here. Thank you so much to ma'am once again. Avi, do you want to add something?
It has been an honor to know Moumita ma'am, and it was a great pleasure to have you ma'am here. And we would be continuing this session with you on 29. Now, as a closing statement, we would all like you to have a close look at the bingo list that is going to be shared, and do share it at all the social media platforms in order to celebrate this month. Thank you, ma'am. You can leave the meeting if you wish to.